So, we've been asked to present a debate of CAR T cells against bispecifics. Now, the terms of reference on the debate are not specified, so we're not talking about particular lines of therapy. But we just thought this would be an interesting opportunity to have some discussion about choices. And I think, for my mind, that we have talked, and you've heard from Cathy and Andrea, about two transformative therapies. And to my mind, it's not a case of one versus another, or one is better than another. I think, to me, it's about identifying which patient to offer one of these therapies to, and at which time, and the right time for that individual patient. But of course, these two therapies, and choosing these two therapies, I think it's really about these all these factors, and I think we have to think about this as we make these selections, and we're lucky that we have these choices, and very many territories that I interact with don't have these choices, so I think we're in a very fortunate position, but it makes the decisions that we have to make very difficult. But because we're undertaking an academic exercise, and the debate is CAR T cells or bispecifics, you're going to hear from Andrea, who's going to give the case for CAR T cell therapy, and Cathy, who's going to give the case for bispecific antibody therapies. And I'd like you to make your mind up, thinking about all the factors that they're going to describe to help us come to some answer to this question. So I'm going to take a vote now to ask you the question, bispecifics or CAR T cell therapy. And I'm going to ask you to nail your colours to the mast and tell me which one of those you would choose. So, who would choose CAR T cell therapy? So, okay, probably about a third. And who would choose bispecifics? Okay, about a third. And there's about a third who are completely undecided. So, the floor is yours. And Andrea?
Yeah,
I'm just going to give us 10 minutes to warm up the debate.
Thanks, Andy. Yeah, I've just prepared 5 very brief slides to make my pitch, but not too controversial or confrontational. Okay, very good. So, yeah, 5 quick slides just to highlight some aspects I think are relevant in this consideration of best sequencing CAR T versus bispecifics. So first, and probably most important one, is CAR T is clearly a curative treatment. We have long-term follow-up data, a clear plateau, no occurrence of late progression events, so around 40% of infused patients are deemed cured, and that's a high bar and the really benchmark we have to compare all other treatments against. And we just don't have the same confidence for bispecifics as monotherapy or combination, whether they are truly curative treatments, and if so, where the plateau will settle. So I do personally think that we've seen excellent, very durable responses. So I think a proportion of patients treated with bispecifics will be cured, but I think it's likely lower percentage, and the jury is still out. We just don't know yet. Secondly, CAR T cell therapy against the general opinion is a well-tolerated treatment, and I think that's even more true now that we have liso-cel available. So the data you see here are the second-line liso-cel real-world data presented at ASH 2024. 45% all-grade CRS, mainly low-grade, 20% ICANS, very small rate of high-grade ICANS, so really well-tolerated. And so the gap between patients who are truly able to tolerate bispecifics and liso-cel or other well-tolerated CAR T products is getting smaller and smaller. And I personally can't really visualize a patient who is perfectly capable of tolerating bispecifics but couldn't tolerate liso-cel. So I think it's extremely well tolerated, and the overlap in terms of fitness is very large. Thirdly, both sequences are feasible, so there are data to suggest that CAR-T outcomes are very similar, whether or not patients had pre-exposure to bispecs, and quite a lot of data from the pivotal third-line studies and real-world cohorts to show that third-line bispecific outcomes are similar, whether or not patients had prior CAR-T. So you can do both from the data we have, but we clearly have more data and more experience with CAR-T first, bispecifics afterwards. And then the big question around patient burden of treatment, the length and the complexity of the pathway. Again, I think CAR-T, yes, we have the long lead-in phase, panel approval, leukapheresis, manufacturing time, but then the treatment is a one-off infusion when patients are often discharged at day 10 or even earlier with liso-cel, then move to the outpatient setting and back to their local care. So for some patients, and that would be a time when they're still not even half through their bispecific antibody treatment. So I think for some patients, the burden with treatment is actually smaller for CAR-T. So it's clearly not a black and white situation. And secondly, I don't think the argument is fair to say in patients with high burden, fast progressing disease, we need to prioritize an off-the-shelf bispecific antibody, because for me, holding bridging therapy is an integral part of the CAR-T pathway, and these are off-the-shelf therapies as well. So I'm quicker in getting my patients to RGDP and RBP bridging therapies than going through the step-up dosing with bispecs. And last but not least, patient preference is key. So we just shouldn't assume and should ask the patient what their view is. And many patients have a strong view. So we cannot just think, well, all older patients would prefer treatment closer to home, or all younger patients will not have concerns about neurotoxicity. It really differs. So very important to have this detailed discussion with the patient. And we have, because it's getting ever more complex with this fast-moving field, we have to be recognizing our limitations. So I think we shouldn't dismiss a treatment that we are not perfectly familiar with. So if CAR-T is in the mix, if it can be considered for a patient, the discussion around CAR-T should be held by a person who knows what CAR-T delivery entails. And I think that's the end of my...
Andrea, thank you very much. So you have heard that there's the data about the long-term survival. You've heard the data about the tolerability of CAR-T cells and the sequencing. And Dr. Kuhln has said to us this is a one-off treatment, which I think she's pushing that off a bit, but it's a one-off infusion. And, of course, the relevance of patient preference. So, Dr. Burton, let's beat that.
Thank you, Andy. Thank you, Andrea. So, yes, I'm talking about bispecifics. Without a doubt, CAR-T cell therapy has helped our sort of evolution in our management of relapse refractory DLBCL. And there was this paper in 2024 in Blood looking at comparing CAR-T cell therapy and bispecifics. This was in third line or later treatment for diffuse large B-cell lymphoma, a meta-analysis that did show that CAR-T cell therapy had superior efficacy compared to bispecific antibodies, although only marginally, but with a higher incidence of severe adverse events. But if you look at the real-world treatment patterns, and I very much knew Andrea would present the UK data, so I switched and used the US data, that really does show that CAR T-cell therapy is only currently received by less than 25% in the US of eligible patients. And this is because of age, poor performance status, comorbidities, or rapidly progressive disease. And I think we do have to acknowledge, as Andy said, that real-world access to CAR T-cell therapy is limited. And I know we're talking about management of patients in the UK, but I do think this is relevant. So, the challenges of CAR T-cell therapy is access and equity. That's undeniable. It is only available in larger hospitals. There is a problem with feasibility of delivery. 10 to 25% of patients fail to proceed to CAR T, and it is expensive. So it does remain, even in this country, geographically and socially economically limited. The other challenges with CAR T is, yes, CRS rates and ICANS rates are less with liso-cel, but they are still higher than you see with bispecifics. Admissions to ITU do remain common for CAR T-cell patients, and many of the patients we see are old, frail, have comorbidities, and they really are ineligible for leukodepletion, bridging, and really unable to tolerate potential adverse events. And there is a significant risk of infection with CAR T-cell therapy. And this time to treatment, I do think, is really important. There is a need for leukapheresis. About 10% of patients fail post that. About 40% progress while waiting. There is this manufacturing time. It has improved with Axicell, but is still considerable with liso-cel. And this need for both bridging and lymphodepleting chemotherapy does increase time to treatment and toxicity. So I think in a lot of cases, patients either cannot wait for CAR T-cell therapy or the treatment is too toxic. And I think in this treatment evolution for relapsed refractory DLBCL, bispecifics are really sort of leading us to treatment options that are more broadly available, more rapidly accessible, and with improved tolerability. And therefore, bispecifics present the solution to the management of relapsed refractory DLBCL. So, and why is this? Why are they the solution? Because they are available and accessible, they are immediate, they are off the shelf, they don't have to go through the national panel, it's just a quick blue tech form, there's no manufacturing delay, they can be delivered as an outpatient for the vast majority of the treatment. They're available at local hospitals. Most district general hospitals are now delivering bispecific antibodies. There's no need to come to a specialist centre. And it is sort of sustainable in the health system. It's a fraction of the CAR T-cell cost. The infrastructure isn't needed. The infrastructure for CAR T-cell therapy is incredible, really. And therefore, this is scalable across health systems. Bispecifics have demonstrated competitive efficacy to CAR T-cell therapy. There's a rapid time to response for most patients with durable remissions. And we have seen efficacy of bispecifics after CAR T-cell failure. There is definitely more data for that. There's limited data in the reverse, although trials like the Portal trial that Andrea is involved in may well change that. And I think one of the most important things about bispecifics is this rapidly expanding pipeline. There's 2 bispecific products that we use routinely. There's 2 more CD20, CD3 bispecific antibodies coming through. There's new bispecific antibodies like AZ, new bispecific antibodies looking very interesting. So I think there's constantly new products. There's new combinations of bispecifics with either chemotherapy or other immune-mediated therapy. We're moving bispecifics earlier and earlier in the time of treatment, and there is better safety. There's no difference. There is. I think this is really important, that bispecifics do provide a much more predictable and manageable safety profile than CAR T-cell therapy. So they're my main arguments. Just a little bit of data. If you compare CAR T and bispecifics in terms of a safety profile, definitely grade 3 or more CRS, neurotoxicity, or grade 3 or more infections are substantially less with bispecific antibodies than CAR T-cell therapy. And this is because of the delayed cytopenias, a susceptibility to infections. There is a risk of second malignancies with CAR T-cell therapy. There are other adverse events, dermatological, cardiovascular, neurological, and there are some patients resistant to CAR T-cell therapy. So I would argue CAR T-cell therapy is not a single treatment, and do not believe that it's a one-off treatment. These patients need monitoring. So just looking at this, the pilot trial. So this was a trial that looked at liso-cel for patients that weren't intended for a stem cell transplant in relapsed refractory DLBCL. So if you look at the pilot, so the use of liso-cel versus Starglow for second-line treatment in patients who are transplant ineligible, in terms of the median progression-free survival, this is comparable or if not better with GlowFit GemOx. If you look at the overall survival as well, it wasn't reached in either of the arms. So therefore, there's sort of an argument for this second-line DLBCL treatment specifically that GlowFit GemOx does represent an off-the-shelf treatment for auto-ineligible patients compared with CAR T. And if you look at the response rates, these are comparable. So if you compare liso-cel for transplant ineligible with GlowFit GemOx for transplant ineligible patients at second line, the CR rates are comparable, if not better, as is the 18-month PFS. And I just want to highlight, this isn't just talking about one drug, not just glofitamab, but if you look at the SOMMO data, so the combination of mosunetuzumab with polatuzumab versus R-GemOx, again, this was better than chemotherapy and therefore potentially better than CAR T-cell therapy. And I just want to highlight this really. I mentioned this UK real-world data earlier. There is now widespread use in this EHA oral presentation that will be presented next month. You know, there really is vast use now of bispecific antibodies in the third line setting and so I think this is, you know, and this is very representative across the whole of the UK, and we even have guidelines that I must commend others for writing that direct us how we deliver bispecific treatment. So, in conclusion, I think bispecifics, because of their combination of their efficacy, access, flexibility, safety, equity, and economics, they are the better choice for the majority of patients with diffuse large B-cell lymphoma. But I acknowledge needs to be an individualised approach, and sequencing of treatment has to be the most important. And I hope that means we can remain friends.
So you have heard that bispecifics democratizes access to therapies and all the socioeconomic consequences of CAR T-cell therapy. You've heard the word that they have competitive efficacy and perhaps a different toxicity profile. And of course, they don't need all the infrastructure of delivery of CAR T-cell therapy. So, Cathy, do you think, however, that you are compromising depth of response by the fact they're just easier to deliver?
So I don't think... So admittedly, we don't have such longer follow-up with bispecifics, but I think that is being gained. I think those patients that achieve CR, for the vast majority of patients then maintain a CR. I would not like to say delivering it because it's easier. I think it's because for specific patients, bispecifics are more appropriate.
Andrea, so, we hear a lot about the manufacturing period, 4 to 6 weeks, and we hear about the complexities of the pathway and the bridging therapies and optimizing bridging and all the rest of it. But actually, we know also that a lot of patients progress during that ramp-up dosing and the weeks after they start bispecific antibody therapies. So actually, probably is the manufacturing period actually quite good to be able to better optimize patients for these immunological therapies?
So you mean...
So you're saying we see people, yeah. No, but saying if you choose a bispec during ramp up and in the first 2 cycles, there will be patients, quite a lot of patients, who progress during that period of time. So the equivalent to that is in the CAR T is the manufacturing space, isn't it? Those weeks, and actually it's just a surrogate for the biology. And actually, the work that you do in CAR T therapy to optimize these patients before reinfusion actually provides perhaps a better environment for the T cell engaging therapy to work.
Yeah, no, absolutely agree. And I think that we should think and move towards bridging therapy prior to bispecs as well. For example, radiotherapy targeting bulky disease. I don't see a reason why this should not nicely work together with any sort of T-cell directing therapy. Yes, in the end, I have to say, both treatment options are very good choices, and there are a few patients where it's clear-cut, fit and well, aiming for highest curative potential, and many patients who would be more appropriate for bispecifics. Ideally, we would like to have the ultimate flexibility, not being restricted by these transplant fitness categories, and just potentially start with bispecifics, then reconsider for those patients who achieve CR whether or not to continue or move to CAR T. Unfortunately, we have to make up our mind early on, and we don't know, but ideally we would do both therapies similar to what we do in the Portal study, peri-CAR T use of bispecifics, and then potentially identifying those patients who would do extremely well or similarly well with bispecs only, and give them the choice. But that's not realistic, unfortunately.
So obviously, I think we're seeing that the treatment landscape is evolving, and that we are seeing currently phase 3 studies that are looking at CAR T cells in the first-line setting in selected groups of patients with large cell lymphoma. We're also, studies, or at least 3 randomized studies involving bispecifics in the first-line setting, which have almost completed or have completed and waiting for readouts. So is this an artificial debate, and how do you think the landscape is going to change in the context of the first-line data?
Well, if I'd make a bet, I think it's more likely that bispecific combinations move first-line, then CAR T remains. I mean, CAR T is clearly here to stay, then it would be second-line treatment for most of these patients. But I think we even have to then consider retreatment with bispecifics later on. So I think it's extremely difficult to predict, but they will probably both treatments will move further up. But I think there's a lot of interesting trial combinations with chemo in the bispecific space. I think that's likely to come our way, but I don't know if you think differently, Cathy?
No, I think I totally agree with you. I think bispecifics are much more likely to be moved up into the first-line setting. I think most of us that treat patients with CAR T and bispecifics would feel much happier with that. I think if we were better at predicting risk, then I think maybe there would be certain patients at first line you might consider for CAR T, but I think as things stand at the moment, be much more likely would use bispecifics first line, and I think defends my total argument.
So, thank you. So, I just wanted to say, I forget to say at the beginning that undertaking this exercise as an intellectual exercise, it doesn't necessarily mean that Cathy or Andrea have a completely polarized view on one of these things or the other. So, I'm going to come back to you. I'm going to ask those people who abstained last time to nail your colours to the mask this time and have a go. So, the debate was bispecifics or CAR T-cell therapy. So, CAR T-cell therapy, let's have a show of hands. Oh, Andrea, you've converted some, definitely. And the bispecs? Oh, and Cathy, you've definitely got some people to vote for you there as well. So I want just thanks very much for this, and thank you, Sue, for doing it absolutely in the spirit that we wanted to. So thank you very much. It's been great. Thank you.